geneticist and the counselor. I think this is a series on that. And today we are extremely delighted. We have a very well-known geneticist, a doctor who turned into did his PhD and did genetics and heads the molecular genetics at Manipal Hospitals. We are so glad to have you here, Dr. Mitesh Shetty. Welcome to the Genomics Gupshup.
Thank you. Thank you, Dr. Anu, for having me. And your topic title is very interesting.
Yeah, we wanted to make sure that, genomics is something that people still look upon as, very difficult. And that I thought, when you add Gupshup, we can make it such that anybody can actually have a conversation and understand. Because all the things that we do, I think currently we need to make sure that we can scale it up to the average person, so that they can understand. But I'm very curious. You're one of the earliest who went from being a MBBS doctor to then I think you moved into a master's in genetics and then a PhD in genetics, if I'm not mistaken. So how was your journey? Why did you choose that path?
Okay, so there is a background here. So I was born and brought up and my medical graduation happened from Bombay. So that time, that is like 20 to 23 years back, in medical field in Bombay, I used to feel like there is a lot of saturation is there. And at those days, people from Bombay, they were, I don't know now, they never wanted to go outside Bombay. Okay. So I never thought of going outside Bombay. So Bombay, there is so much saturation in medical field. So I wanted to do differently, something different. So actually, when you ask me or when I think, I did that time some Google. I don't know what form of Google or was there in that time, but it was through net only. I came across this course from Glasgow University, UK, where there's a master's degree from medical genetics. So that fascinated me, it is something different and maybe, I felt at that moment that it has a lot of future because I did some more information, then I came across that the future will be like that, where with the gene therapy, you can cure this hypercholesterolemia, like how you have angioplasty. So you drill those blocks. So something like that with a gene vector, you can clear those blocks. So that fascinated me. And then I opted for genetics. And this is how I went into genetics. But today I don't feel I regret. I feel like it is one of the most fascinating. And somebody called me 2 days back, your genetic is so much glamorous nowadays. So everybody talks about genetics and all those things. So that way, so she said somebody wants to come into medical field and she is visiting hospital, and I want to make sure she visits your department because yours is a very glamorous. So I don't know what do I say, it's a compliment or that way. So, but it is growing very rapidly.
So you mentioned the term hypercholesterolemia, right? So maybe if you can explain in simple terms what that means.
So in a simple term, this is nothing but hypercholesterolemia because of the increased cholesterol, which leads to, in a simple term, heart attack. So 20 to 25 years, that was one of the biggest thing. Everybody was getting heart attack and it was coming to females and all those things were happening. So cardiac was big thing 20 to 25 years back. So that is what what I thought about it is still not happened, but I think it can happen very soon. So the gene therapy in the removing the blocks, I think that can still happen. So that is same thing. So that, as I told you, that fascinated me and I landed up in there. But there is a lot of gaps are there, I feel. When I went there in UK, then I realized there are a lot of things are happening in genetics field. Till that, though I was from Bombay and I didn't hear about genetics. But when I went there in UK, then I came back in between. So I saw a lot of things were happening, but that time we had very limited resources and, people may not know there is an NIRH in KM hospital. and all those things. So that way. So yeah, means a lot of gaps were there at those times.
So this
Medical
was
field.
around what year was this? 2000?
This is in 2000, 2001,
2000.
around that period.
So I think that was
22
around
years back.
that was around the time we started our first company in genomics. But of course, that was more to do with, I think we worked mostly with pharmaceutical and biotech companies. It was not to the patients. I think at that point of time, it was still too early to be in the clinic. But at least it was, we were doing some work in that space. But so you've seen this grow from, you were a master's student around 2001, 2, and then you did a PhD. So from your viewpoint, and you are now at a point where people are telling you this is a very glamorous field. How did you see this whole journey from 2001 onwards in terms of how was it a slow pickup? Was it quick? Or, I mean, how difficult was this journey in your opinion?
I don't know. It was, I won't say difficult, but I think challenging. It was challenging and in different ways, to create awareness or explain doctor about genetics and to the other people, relatives and friends. So what do I do? So they will ask, okay, genetics, okay, you are doing research. So those type of question, it was challenging to say. So then I still remember one of my uncle in the sense he was staying in the apartment. So I explained him all these things. And in fact, his wife had a breast cancer. So I explained him like this can be the genetics and all those things. But he said, you tell me treatment. So, and that was a lot of challenges. What is the treatment? There is no treatment, then why? So that way it was very challenging. But yes, it was always about creating awareness among the clinical field, medical doctors primarily. So what we talk about awareness is now in the public domain, but we were talking about awareness for the medical doctors to be aware about what is genetics and what is important and all those things within the very limited resources what we had at that point of time. So that way. So those days we were talking mainly about Down syndrome. So what is Down syndrome and all those things. So creating awareness. So that way. So I still say that I get references more primarily from the obstetrician than the pediatrician. So the family who have a child with a problem, ideally we should get a reference from a pediatrician. So they would refer to genetics and all those things, and then they come. So those days, first of all, they were not aware about it. So they'll straight away say there is no treatment. So, and there won't be any follow-up for all those things. So they will not refer. And secondly, when they want to go for next child, when they meet an obstetrician, then they'll ask whether it can happen again. Then the obstetrician will refer. So this is how it has to happen. So I used to get child reference from the obstetrician primarily. So that way. So we used to try and understand, and in a lot of limitation, we used to guide them or help them in whatever way we could do. But now it has grown a huge thing. So we can help in a better way. I won't say that no, we can help them in each and every case, but it's much better what we had 22, 25 years back.
So you're saying that earlier, even though there were children with disorders that maybe we could supplement with maybe some small interventions, we were just not aware that they were happening, and parents and doctors both were not aware. And I think, I guess that shows the importance of maybe newborn screening that now is beginning to take shape in some form.
Yeah, newborn screening, and then I would say different, you need to divide it, one, whether we could diagnose it. Okay, so that had a limitation. Then second, how it could help the babies. Not exactly therapies, the treatment, but other therapies and all those things. We had very limited. And another thing was, the challenging part would be, we used to get patients from all over Karnataka, all over India. From that, people used to come to Nimans, from Nimans to us, and then very limited. So The other problem we had, whatever we have to do, diagnosis or whatever, we had that 1 hour or 2 hour where we have to do everything with those limited resources, because the patient is from outstation, they have to go back, they don't have records, so all those things. So that was always a challenging. Now the things are changing. Now what we see patients, so what I'm seeing, and those days, what we used to look at, diagnosis, with whatever limited resources, and prevention in the pregnancy, that one. So we never had that chance, or we never had that opportunity, or we could do anything to help the baby, because therapy also was very limited. And another thing, they're from outstation. So now what is happening, we are seeing a lot of patients who are local or surrounding our places, so that we can follow it up. And another thing, what we are seeing now, lot of cases which may be milder cases, and some with the birth defects, like heart defect. So they want to know whether their child will develop a heart defect. So those patients are coming into reproductive ages, and they want to understand whether it can happen again and all those things. So we are seeing all these different types of patients, and more of clinical follow-ups. And apart from the treatment, it's not that much greatly increased, but still the supportive management system, there is a drastically change in the therapies and all those things. So we can help them in much better.
So now that, you mentioned that earlier we had all these challenges, today, do you think the situation is much better? Because clearly, I think there's a better understanding of genetics compared to 20 years ago. And there is also more availability of, of tests and diagnostics in this space. So do you think the challenges are still the same, or now the challenges are slightly different in terms of, from a patient's point of view and also from a geneticist's point of view?
So I would put it like this. So those time told you we had very limited resources. We could do only karyotyping and fish for very selective microdeletion, 2-3 common microdeletions, and common condition SMA, DMD. DMD also we had a lot of restrictions. We could not check all the exons. We had common exons and all those things. And we could not check point mutation and all those things. Even in SMA, we could do only deletion duplication at later point of time. And then we could not do point mutation. So these are the common conditions where we still had a lot of limitation. But genetic has evolved. So from doing karyotyping to from the common mutations, then we moved to chromosomal microarray, where we could see those chromosomes in a expanded view, and where we can see microdeletion and duplication, which will not be picked up in the conventional chromosome test. Similarly, gene tests also we moved to NGS, where we can sequence multiple genes. We can practically sequence the whole genome and all those things. So we had got this development since last maybe 2013, around that. And so we used to feel now we could diagnose everything. Okay, as a geneticist, we were very much excited. Oh yeah, now we got this thing, the depth is so much, we can sequence everything, microarray and all those things. So we had a lot of expectation. But slowly we realized, in science, there is so many things still which we don't know. Even with all this new and technology, we can detect only up to 50%. 50% still we don't know. So this is one realization sort of we had in our genetic, evolving this thing. But now, yes, it is, we can do a lot of things. But yes, the counseling is very important. Making them understand what we are looking at to it, what we can get into it, as the data is too huge. So there are a lot of things which we don't know, what we call as an unknown significance. So counseling is required and all those things. That is the challenge now what we face. And the pregnancy, as usual, the prenatal was always a forte of Manipal Hospital. We always used to see patients for pregnancy and all those things. So coming late, and then restriction of taking any action, PCPNDT Act, you have to take before 20, now which has been now extended to 24 weeks recently. Other than that, earlier we had a lot of restriction. We have to finish everything, whatever, by 20 weeks, all those things. So yes, it has improved a lot. But yes, at the same time, we need to counsel. Counseling is very important. Patient need to understand genetic tests are not like biochemistry or other histopathology test, and which can change also. If you are having fever or infection, then it is different. And if you're not having it, is different. But genetic changes, they are there lifelong. So that way, so counseling is very important.
So do you think that, if we are able to, bring all the, the cost of the sequencing down, which we are now talking about, that we'll bring it down to $100, right? I mean, a few years ago, actually, Illumina said that. Now we heard another company say that we'll get it down. Of course, you said that we have a lot of data, but challenges still exist because people don't understand easily, and we need to do counseling. But do you think that when we do get to that point where, let's say, we are able to educate more doctors about the value of genetics, we are able to educate the masses, but from a pure technical standpoint, do you think that when we get to a really low cost whole genome sequencing data, do you think that will solve all our problems?
No. So you have to understand, it will be good to understand. I always used to say that you have to always break up in two parts, genetics. So, or for that matter, any medical condition. There is a diagnosis and there is a treatment part of it. So this is, I used to say early days, like, when people used to ask me, what is the treatment? So I used to say that, my patient, see what happens, a patient who is sitting in the medicine OPD or OBG OPD or any other OPD, what does he feel, like what he's expecting treatment-wise? That somebody can understand and can cure his problem. So our patients also like that. So because what happened, by the time they come to our department, they have gone through so many different doctors and different testing, and they have almost given up. So they don't have much hope. So somebody, they come to our OPD, what they have expectation is that somebody can understand their problem, what they are going through. And that is what we are doing that. So we can make them understand what they are going through, their child problem and all those things, and what we can help them. So their expectation is somebody can understand their problem, not that by the time they come to us, they know there is no treatment. So my OPD and that medicine OPD, I say practically it is same. You are treating the expectation. So that one. So any condition, now also I say, you have to first get the diagnosis. Then comes the question of treatment. So unfortunately in genetics, what happens, they'll ask first a treatment without the diagnosis. So I said, you have to understand any condition. If you don't know the diagnosis, how you will treat? The only thing is that genetic, maybe the testing is costly right now comparatively, but it is still cheap what we started with. But this definitely will help in managing the patient. So in so many different ways. So that way, so we know what we are dealing with it, how we can help the baby, and we will know what is the clinical trial or research is happening in the specific field. If you say genetics is little complex than any other medical condition, your treatment is not for the condition. Your treatment is for the how the etiology is there, what is causing the problem. So if it is one exon, then that exon or DMD, that is a different treatment. Similarly, different exon will have different treatment. So you cannot have blanket treatment for a condition. So you will know where to follow or what exactly you are having defect. So in today's time, in world browsing web and all those things, that know where you want to follow, very specific. So you can be following up with those specific things, and a lot of clinical trials will come in India. So all those things, it will help. And more importantly, if you want to go for next child, it will definitely help. So that way, so I always tell them diagnosis is still very important. It will help you in so many ways, not only straight treatment. Indirect supportive treatment, it can help in a lot.
So you're saying that currently, I think a lot more patients are coming after they've seen many doctors, and then they come to genetics as a last resort. But if we twisted that around and we said, first get your genetic profile done, do you think that that will make the whole diagnosis odyssey that people go through a much more, easier way for them to traverse? Because I think, it will probably be way cheaper for them if they got that analysis done upfront, rather than say that I'm going to first talk to my first doctor, then second doctor, third doctor, fourth doctor, and then finally come to Dr. Mitesh Shetty and understand ki hua kya tha, right? So I think, I mean, if we want to change that whole paradigm, do you think that if we were somehow be able to convince people to do that in the beginning rather than as the last?
Yeah, means what you're saying is correct, but I'll put it a little differently. Now, this is what I used to see early days. Means I'm talking about this like the people coming to us very last, and now because of the awareness and all information is there in your hand only. You don't have to go anywhere. Okay, so now things are changing a lot. But yes, what you were touching upon that we always say that genetics there is no treatment, so only prevention is there. So prevention may, yes, how we can do early prevention, what you talked about, newborn screening, so that can help. And then what like a pregnancy screening, all those things, and then common conditions, and then if there is a history and there is a consanguinity, when they have to come for genetic counseling. So all those things will help in identifying and preventing those conditions. But as I told you, the other part of it, as we are having higher end technology, the data is huge. What we get, we don't know how to correlate. So instead of helping them, we should not confuse them.
Absolutely.
Okay, and so many times that decisions, and you have to understand, like nobody is going to take any chances. If you say that we don't know, so they will take the other extreme side only. So that is one challenge what we have, that is yet to be. I have not seen people changing that, but that is big challenge. So the counseling is very important. What you're dealing, I would say testing is going to be simple. Mm-hmm. Okay, like what you said, $100 and all those things. It can happen, but more importantly, counseling, pre-test counseling, post-test counseling. What is this test is for, and what are you expecting in this? And then after test, all those things. Those are very important. That I feel that has to be there. And then I always say that it is the patient or the individual has to take informed decision. So that way. So it is possible to test, but with understanding what they're dealing with and all those things.
So do you think that a lot of the physicians who are recommending, we are seeing a different kinds of, like, is a trend in terms of what kind of tests were done, let's say even 10 years ago versus today? Is that changing? Because you said in the beginning we did mostly, we had access. One was the limitation on technology, right? We had karyotyping and a little bit of fish that came in and so on. Today you have access to NGS and many other technologies that are there. Do you think that we are seeing some sort of changes in the trends, or is it still the similar numbers that you see instead of 10, you're seeing more karyotyping, like from 10 you went to 100 versus, or is it like the order in which people are looking at has that changed dramatically or not really?
So I would say people are being investigated for genetic condition. Now, whether that investigation is done correctly, that is what I have that lot of problem there. So one answer, yes, lot of genetic testing being ordered, okay, being carried out. Now, whether that test is done correctly, that is I will be little difficult to answer whether that is correct. So that, as I told you, still awareness has to be there about what test, because each test is specific for something. Though we are doing a lot of high-end tests, but that doesn't mean, as I told you, even with the whole genome sequencing and all those things, in a very strong case of genetic, we can still identify only up to 50%. Okay, I'm saying very strong. Okay, so forget about all small doubts and this thing. So they're doing this testing and detection rate, And instead of getting detection, you are getting confusing them with something else.
True.
So that way, as I told you, counseling is very important. Tests are being ordered, and obviously the lot of challenges are there. So always, so I speak to a lot of people, lot of clinician and lot of lab people. So they said like, no, it is good in a way. It is they are promoting genetics, so awareness is happening. So it is helping in that. Now the second part, like now how to do correct, yes, still we need to refine it. I think nowhere we can do completely correct, but yes, slowly I think the things will evolve, and right now there is no regulation also. So all those things will come into picture. So it will be good. At least I feel it is accessible. People can access genetic testing, genetic counseling and all those things. So people used to say like, no, who used to come to our hospital that we are coming from far. So how far means from other part of the Bangalore. So that means, so that is like 15, 18 kilometers. I said people to us visit from the Northeast, Assam and all those things. So that way. So, but yes, now today afternoon only I got a call from Dubai. So he wants to have video consultation. So their accessibility to the doctors and to the testing has increased. So that is one good part of awareness that is there. Now, little bit of fine tuning and all those things still we need to.
Yes. So I remember one of the things that our team always keeps asking is making sure that, when you order an NGS test, for instance, that the history is properly taken, right? I mean, because you want to know what you are looking for.
Yeah.
Sorry, I think I lost you for a second.
Yeah.
So basically, I think one challenge, of course, that we are seeing sometimes is that we have to call the patient again and find out what the real history is, because typically the requisition is not filled in with details, because they said, anyway, you can do the research and find out. Now, what they don't understand is that there is a lot of things that you can find out, but you want to be able to help them understand and analyze based on their medical condition. That was number one that we see, at least. And the second thing also was, like you were mentioning, that, will that cause more confusion, right? So for the viewers, I think one is that there are some changes or mutations that are very directly linked to disease, and there are others that we still don't know enough about, rather. So the question is really, how do we report them so that, there is understanding of that, but it's simple enough for the physician and simple enough for the person who gets the report as well, right? I think those are challenges that we all have to deal with in the genetics world. Do you also agree with that, or do you have a...
No, I agree in both the way. One, when we are doing the testing, so we come across a lot of information which we don't know how to put it, this thing, whether we should put it or not, but we counsel them and we tell them all those things. So it becomes easy that we want to restrict ourselves to certain thing only. So that, as I told you, counseling is very important. And I see the other side also. The patient who have done investigation outside and then they come to us for a counseling. And I have seen the worst side also for all those things, what I said, where there is a VUS. VUS is that there is a change in the gene, and that change we don't know whether it is abnormal or normal. So that change, for that, some people have terminated the pregnancy, and then they come to us, and then then they start crying, when they realize that was not correct to do. So that side also. So the counseling is very important. So what you're saying, the diagnosis or the referral reason is very important that way. So as I told you, the awareness still need to be done because see, we primarily get requests from a specialist. So there also awareness has to be there. Okay, so not just testing. Now I got one request yesterday evening. No, they want to do for polyposis. So the lab person doesn't know. And then I have, luckily it was within our group. So I called up the doctor and I asked him. So there also, they knew that no, we need to do, but again, which test we need to do, that they were not aware. Whether we need to do the germline or somatic. So I had to that education part of it, or sometimes the fine tuning about it. So those still required, because how we are going to report, because what you are going to check, you are going to check so many genes, and so many will be in, normal and abnormal also. So I don't know how to report. So that part is very important. The referral reason and the family history. That way. So that's what I'm saying. Counseling is very important in genetic testing. Without counseling, it is very difficult. It is something because it will create a lot of problem.
I think it causes more confusion to the end.
Yes, as I told.
So, I mean, there are, clearly, I think many years ago, and I think around 2001, 2, when both of us started, I think Angelina Jolie was, I'm trying to think, it was around 2005, 6 maybe, or no, 2013. Yes, it was around 2013 when
very late, little bit.
Yes, it was 2013 because it was when MapmyGenome started, not Awesome. And I remember there were two things around that time. One was that Angelina Jolie was on the, she had written this article and she talked about BRCA1 and 2. Now, clearly, I think, hereditary breast and cancer, ovarian cancer have a lot more genes. But do you think this is what they call as the Angelina Jolie effect? And do you think we need more Angelina Jolies or more some other celebrities to sort of create that sort of awareness in other areas as well?
That one thing is there. We need more of this, because one part is definitely there because of the Angelina Jolie. A lot of people were aware about the breast cancer and genetic and BRCA1 and BRCA2. That is there. That is definitely there. And, but yes, as I told you, counseling is very important. BRCA1, and if I say genetics and cancer, they're very fastly evolving. Okay. So if we know, this BRCA1, BRCA2 story, if I can tell you, 2007 or 8, I used to get a call. So I used to say like that early days, genetic is inquiry counter. Everybody will call. Oh, okay, this test is there or that test is there. What is the cost? And they will not turn up because the cost is very high. So this particularly BRCA1, BRCA2, if I remember, those days it used to cost somewhere around 64,000 rupees. And that was for only common mutation, not a full gene sequencing. So if I say how the prices have come down.
Absolutely.
So less than one third of the price, you're able to sequence the gene. Sure. Okay. And that time you're just checking the common mutation, maybe, how do I put it in a number?
Yeah.
Very few.
Hotspot, this thing, right?
Few percentage of that. So that way. So people used to inquire. But as I told you, I'm learning the other part of this thing. Everything means it is good in some way, and some we still need to correct those things. So Angelina Jolie effect is good that they created awareness about genetics and BRCA1 and 2. But when you want to do, there are more than BRCA1 and 2. There are some more genes are there. It varies. There are 24 odd genes are there. And as I told you, 24 odd genes, what we know now, maybe after 1 year, 2 years, it may be more. And this 24 gene, again, not there equally shared. So BRCA1 and BRCA2 again is a major important gene for breast cancer, hereditary breast and ovarian cancer. But other genes are there, but they have different percentage. But if you want to rule out, you can rule out that also. Understanding the family history, as I told you, family history is very important. Genetic testing understanding is very important. Since you talked about the breast cancer, I always tell them that everybody is at risk. Every females, they are at risk of developing a cancer at some stage of life. Now, what is the risk? Now, because of the history, your risk is increasing further. Now, if you can identify that it is a hereditary, then your risk will increase further. So again, that gene, having those genes doesn't mean that you will definitely develop a cancer. Your probability is increasing. Your surveillance has to be little aggressive. So that way, both part has to be very clear. So that way. So there also that US comes into picture, variant of unknown significance. So we say that practically it is negative report. So this is just a technical thing. So all those counseling is very important. So some condition we still don't know. So we are still trying to understand. So more and more gene will come up.
I think one thing that we always tell our patients, and we did that even for simpler conditions as well, where we said you have to have genetic counseling, and we encourage everybody to do a counseling, because I think that sort of helps them understand the choices they have. You can't change your genetic code, what you're born with, but what you can change is the outcome of health that you can get based on what you do in terms of both lifestyle, but also in terms of how you plan a baby and so on. So one more quick question before I move to the fun part of the discussion is, do you also see a lot of pharmacogenomic testing at your lab, or is that something that is very occasional?
So as I told you, genetic is very much that I think itself is having so many subdivisions.
True.
Okay, so it is going to develop into further subdivision where you will have a cancer separately, reproductive genetics separately, and this Mendelian disorders separately, and those things. So, and maybe further more. So I always say that if you talk about lab medicine, so in right now, if you include genetics also into that, so primarily the investigation is biochemistry. So that is on the highest thing. So, and the genetics should be on the least side most of the time. Okay. So I said, I hope that after 5 years or 10 years, it will be reversed, where the genetic will be the main investigation and the other thing will be less or equal that way. So the investigation is important for anything. Sorry, I lost your...
The pharmacogenomics.
Pharmacogenomics. Okay, so pharmacogenomics, precision medicine, what is going to come? As you know, precision medicine is going to be the future, where you will have a drug which is sort of not personalized, but precision, which is for this certain genetic makeup will benefit with this drug. So we have started getting this request. And we are in the pipeline. I have got one request from my nephrology team. They want to do certain gene to check for the whether that is there or not. So that is picking up. And I happen to know a lot of things are happening in the other specialty also, like hemato-onco and all those things. It is happening. We are getting into that. So that is also something which can branch out altogether, completely different thing. So as I told you, a lot of things are there. Infectious is going to be another thing that way. So a lot of things can happen. Genetics can divide further into so many different specialties.
True. I think one thing we did was to create two kinds of pharmacogenomics profiles, right? We said we'll do one, which is a low cost profile that you look for 105 drugs to see if you're based on the CPIC guidelines, whether you are likely to respond well to a drug or if it's going to have adverse effects or what kind of dosage is required. So that we are doing it more from a hereditary point of view. And then, of course, I think depending on for cancer treatment and all, whether we can use blocks and whether you can use a tissue sample to be able to help them understand that. So those are things that we've been doing at MapmyGenome, but maybe we can have a discussion about that sometime later. So one more last question. Do you think the pandemic did us more good for us people in the genetics world or more harm? Taking aside all the other harm that it did, of course, but from a genetics point of view.
I don't know how to put it exactly. What I can say, the impact, the positive or negative, I don't know. So if you ask me, because of this pandemic, the positive thing, what we feel is genetic counseling, video consultation. So people during the pandemic also, I got some video consultation from the Allahabad and all those people. So that I feel that was one good thing that they could do the search and identify, and we can help them from Bangalore to them and their pregnancy and all those things. So that is one thing, video consultation from different parts of India or abroad. We have done a lot of things from the UK, Australia, and so many US and all those things. So that is one thing which helped or a government eased, and it helped doing this. The other thing, main importantly, I feel because of our understanding of this newer technology, sequencing, we could understand the virus quickly, and definitely it helped in tracing the origin and making the vaccine faster. I think there even the field, the genomics had helped in dealing the pandemic. The negative side, what I felt is something which is there, lot of pregnant ladies we deal with. So they missed their screening, their important scanning and all those things during pandemic. And the other thing, what we see in the children, because of pandemic, they could not go to all their special therapies, physiotherapy, speech therapy. So they had a lot of, limitation. So that is what I felt from the patient point of view, what we deal with. So these are some of the things which had more negative than some, but positives also were there because of genetics. And then another thing, as a genomic department, what I got little people, everybody knew there is a genetics. Yes. Okay. So little bit indirect awareness, and then, you have to look RT-PCR, all those terminologies and all those things. And even in early stages, even the hospital asked whether you can sequence the gene and all those things. I said, yes, we can sequence. We have the technology and we have the kit available. But that time, a lot of ICMR restrictions were there. So means they gave some importance to genetics in a different way. So that way. So that happened during this pandemic.
Great. So now I'll move on to the rapid fire. And I think since you are a MBBS doctor and a PhD doctor, I'll call you Dr. Mitesh Shetty. Just like
you can call me Mithesh Shetty.
No, I'm just saying, we should add that extra doctor in this thing. So what would your alternate career be if you could have one?
Okay, so I don't know how to answer that. All these are very difficult. If you, that time, if you would have asked me 22 years back, there were only two options, either medicine or engineering. So I think the engineering I would have preferred at that point of time. If you ask me now, maybe in the hospitality business or the farming, all those things, maybe at this point of time.
Great. Do you read books? Is there a book that you can recommend?
No, I'm very bad in reading, and I don't do much reading. I start so many things, but I don't complete it. So I'm very bad.
Movies? Do you watch
movies? Yes, like any other. I see movies. So I like movies which is like motivational, and very rarely which is related to our field. So those type of movies and some messaging flow like Andhi, Main Azad Hoon. Then if you ask me genetic wise, like I liked Tare Zameen Par, because there was something about the special children and all those things. So now those type of movies I like, and inspirational, those type of movies I like.
So you're a role model to a lot of people, but who is your role model?
I don't know whether I am a role model, but yes, I didn't have any specific role model, but I used to see a lot of, inspire from a lot of teachers at different stages of my learning. So I'm still learning. So early days, in the college days, we had our Professor Desai, so who used to make teach us physics. So it used to make so much interesting that we used to like physics. So that, and he made very simple and could relate to any day-to-day life. thing. Then in the later stage, and if you ask me now, I admire, I don't know what is the correct one, admire Dr. P.R. Krishnaswamy. You won't believe, he is 91 plus.
Wow.
Okay, and he would be much double active than me and you. Okay, so and he's still so curious to do something new. And so I admire him. Like, no, I've told him so many times, and so many other people, that no, we should sequence your whole genome to understand, like, no, how you are so sharp and attentive.
So actually our t-shirts say curiosity is in my DNA. So I think we have to find him and give him that t-shirt. All right. Thank you so much, Dr. Mitesh Shetty. It was an honor and a pleasure to have you on our show. And hopefully you'll get to meet you in Bangalore, or if you come to Hyderabad sometime. Thank you very much. Thank you.
Thank you. Thank you, Dr. Anu, for having me and giving a little bit, as I told you, a Gupshup. It was very nice title. I felt like, no, chai pe charcha, like, no, how you can make genomics, which is so dry and dull and complex, to make it very interesting.
That's the part. I don't think, I mean, I think it is very interesting, and I think we want to make sure we pass on that message to everybody else as well. So yeah. I think we'll have to all figure out a way to make sure that our subject doesn't remain elusive to others, and that it's something that's within their reach. So thank you again.